COVID-19 virtual grand rounds with Dr. Daniel Griffin. My name is Jolly Amatya, and I've been engaged within the United Nations space for the past decade, and I've been working on a range of areas of the work of the UN at all the levels, particularly in the design, the implementation, monitoring, follow-up, and review of sustainable development policies. And today it is my honor to introduce you to our special guest, Dr. Daniel Griffin. He is a renowned physician, scientist, educator, researcher, clinician, and an author. He's board certified in infectious diseases with expertise in global health, tropical medicine, parasitology, and virology. He is an instructor in clinical medicine and an associate research scientist in the Department of Biochemistry and Molecular Biophysics at Columbia University. He is also the chief of the Division of Infectious Diseases at Pro Healthcare and the president of Parasites Without Borders. Dr. Griffin's role has been pivotal in disseminating clinical updates since the pandemic started and has commendably managed to bring together his current relevant research and clinical practice effectively. He has recently co-authored the American Society of Hematology ASH 2021 guidelines on the use of anticoagulation for thromboprophylaxis in patients with COVID-19 and the importance of understanding the stages of COVID-19 in the treatment and trials, which has significantly enhanced the knowledge of clinicians worldwide. And today's discussion will be especially relevant to clinicians as he'll be discussing different phases of COVID-19 and the therapeutic modalities that are available to manage each one of those phases. And especially in the context of global efforts to develop safe and effective COVID-19 vaccines, even though we've yielded remarkable results, the global community today is facing scarce supply. We are confronting a distressing reality as vaccine distribution remains almost non-existent in many of the poorest countries. And as we're looking forward to a pathway out of this pandemic, we need bold, innovative policies that ensure fast and fair distribution where a globally coordinated strategy, epidemiology, efficacy, and ethics can be fully aligned. We'd also love to hear your take on this later towards the conversation, Dr. Griffin. I would like to mention that the format for tonight's webinar will be a presentation by Dr. Griffin, followed by a Q&A from our audience. I'd also like to quickly thank Dr. Vishal Bhandari, Dr. Digvijay Raja Mahat, Dr. Roshan Lal Shrestha, and Dr. Sargam Raja Mahat for their efforts in putting this critical and a very important conversation together. And I must also mention that I recently discovered that Dr. Griffin, you've actually been to Nepal in 1993. Would love to hear more about that as well. So over to you, Dr. Griffin. Thank you so much for your time, and we really appreciate your public service. Thank you so much. Over to you.
Well, thank you so much, and thank you to everyone for taking this time. So let me go through. Part of this will be a presentation, trying to present a lot of what we currently understand about COVID-19, stages, timing, therapeutics, but I'm going to leave plenty of time at the end for questions, because I think hopefully that will be a very helpful part of this presentation. So without further ado, let us get started. Timing matters. I think that is something really critical that we've learned that's been reinforced over the last year with regard to COVID-19. And what I'm going to present here is a way of looking and a way of understanding the stages of COVID-19 that really was a collaboration of dozens of physicians, scientists, clinicians throughout the world, actually. It's a little painful to get everyone on the same page, but we tried to take everyone's impressions, what does science tell us, what were people seeing, and come up with a way to understand the timing in COVID-19 so we could better manage these patients, also so we could better study different therapies, see what might work when. A lot of times when something didn't work, it might have been used at the wrong time in the wrong patient. So let's go through this. I'm going to lay them out, and then we're going to go through each one of these periods and phases with regards to what is going on and what therapeutics we know or have evidence supporting difference. So the three periods. The first, and this is the hopefully the period that a lot of people listening are in, the pre-exposure period. This is before someone has been exposed to someone with SARS-CoV-2, the virus that causes COVID-19. Unfortunately, some people actually have a significant exposure. They've been infected with the virus, and there is a period, an incubation period that we'll discuss from the time of exposure, which then ends when you get into a period where the virus can be detected, the detectable viral replication period. That brings us right into when the clinical stages or the clinical phases start. This is the viral symptom phase, that first week. We'll discuss what can make a difference, what you should and shouldn't do during that first week. Then we get into that early inflammatory phase, the cytokine storm that people have certainly heard about. Then, and I always think this is an important distinction, we move into a phase when we might actually see secondary infections. And I like to point out that this is different. Most people coming into the door, coming into the hospital, showing up initially, it's a viral infection, usually not bacterial at that point, usually not parasitic at that point. Then a later stage that we started to first identify in children, the multi-system inflammatory phase, and then something that is growing importance, the tail phase. For a lot of individuals, this is not just a 1 or 2 week disease. This could be something that impacts people for months. So let's start working through these stages. So I outline it here. We have very broadly, a period when there's viral replication, a period when there is inflammation, and then we can even break these down a little bit further. So let's start here with the pre-exposure period. What are the most important things to be thinking about? What therapeutics, what can we do during the pre-exposure period? We've actually learned quite a bit. We now have, I think, very solid evidence supporting the role of masks, properly worn, properly fitted. I like to point out to many people, you have a mouth, you have a nose. If you just cover your mouth, you're leaving both of your nostrils out there, breathing in, breathing out. That is not proper masking. Physically distanced. This is actually, we like to use the word physically distanced as opposed to social. This has been a tough time with a lot of people being separated from one another. We've now learned that first 3 feet gives us about an 80% reduction of risk. You get out to 6 feet, it's 90%, but you can see most of that benefit is in the first meter. You get a little more benefit going out to 2 meters. Really dramatic thing we've learned over the last year is outdoors is much safer than indoors, about 20 times safer. Another thing, limiting the size of gatherings. Every person you add is one more person who might be showing up with the virus. So that's the logic of limiting the size of gatherings. Washing hands and hygiene, they can help, but I think our CDC here in the US has pointed out for every 10,000 cases, only about one of those cases is from fomites, from touching a surface that was not adequately cleaned. So all this bleach, and we like to call it hygiene theater here in the States, that's a little bit overdone, maybe a little too much bleach, but washing your hands, that is still critical. Testing. What we've learned about this disease is a lot of the transmission occurs either pre-symptomatic, so prior to symptoms, or in people without symptoms. About 50% of the spread is not by people who have symptoms, but by people in these other situations. So testing is the only way to pick up about 50% of the people that are going to be spreading this virus. Symptom checking, that helps a little, as I mentioned. About half of the spread is by people with symptoms. People with symptoms, we're not sure a lot of our screens, our checking is making as much of a difference as we initially hoped. And vaccines, let's spend a little time on that. I'm going to talk a little bit about active, and I'm also going to talk about the passive and where are we with those. So vaccines, there really are 4 major groups of vaccines, and not everyone in the world has access to the same vaccines. Here in the United States, the first vaccines that we started using widely were the mRNA vaccines. Pfizer and Moderna actually came out with these and started to be used in the States in December. We have our viral vector vaccines. J&J is the big one that we've started using here in the United States. Sputnik V, the Russian adenoviral vector, and then the AstraZeneca. We'll talk a little bit. But what are these different? What are we talking about before I sort of go through all the classes? The mRNA vaccines, we're introducing, I like to say, a sticky note, an instruction manual, so that your body can take that RNA and then they can actually go ahead and make the spike protein, use that spike protein to educate our immune cells. So Pfizer and Moderna are doing that. The adenoviral vector vaccines, these are actually one step backward. We're taking basically a common cold, which is a DNA virus, and your body has to then take that DNA, turn it into RNA, and then make that spike protein to educate your immune system. These are vaccines, I like to say, are not just brand new to the scene. We actually use this technology over several years, last couple of years, to end a large Ebola outbreak in West Africa. This platform is something that we were used even before COVID in 193,000 individuals in West Africa, children as young as 4 months of age, pregnant women, nursing women. So sort of a large group. And now we're seeing, again, this spread throughout the world. We'll talk a little bit specifically about AstraZeneca in the context of Nepal, and also with some recent issues that have arisen. Protein-based vaccines. This is really just getting to the end of the line and saying, instead of all this, make it yourself, why don't we just give a person the protein so that their immune system can see it? So we inject the protein. Novavax is a company working on this. This is a traditional vaccine that we use for shingles vaccines, for HPV, for hepatitis. So this is one that is already being evaluated in the UK, and we're finishing trials here in the US. So this will probably be something before our FDA in May. And then the inactivated viral vaccines, right? This is very much the traditional technology. You grow up a whole bunch of the virus. This is like the Salk polio vaccine. Grow up a whole bunch of the virus, and then you inactivate it. So all you have is that protein, that genetic material. You inject this inactivated virus. It is not replicating. It can't make you sick, but it gives your immune system a chance to see what this virus looks like so it can become educated. So the Sinopharm is grown up in cells. It's inactivated, not with formaldehyde like the old, but with beta propiolactone. This is the Chinese vaccine. The data on this is pretty impressive, so we'll be talking a little bit about that as well. Now, before we go to the incubation period, I just want to give people background because we're going to hopefully do a lot of questions about vaccines. These vaccines are really impressive as far as safety and efficacy. And you'll hear a couple numbers, and we'll talk about this in our Q&A. How good are these vaccines at keeping you from ending up in the hospital, keeping you from dying of COVID-19? They are nearly 100% effective in the people that were studied. They are also really effective at keeping you from even getting mild cases of COVID-19. And actually what we saw in the studies, we're seeing even more impressive results in real world. Israel is sort of in the front, followed by the UK. The US here, we're a little behind, but we're seeing after just the first shot of some of these vaccines, about an 80% reduction in your chance of even getting infected, even asymptomatically, getting up into the 90s after that second shot. And even the people that do get infected, that do test positive, very much lower levels of virus. We're starting to treat these people in the US as individuals who can't transmit once they've been vaccinated. So really impressive, and we'll talk about safety data as well. But what about this incubation period? You've been exposed, and now you're waiting to see what happened. Now, the incubation post-exposure period, what is this defined as? Well, the highest risk is within 6 feet for 15 minutes cumulative, no masks indoors. Now that we're seeing changes in the sequence, we've actually in the US dropped that to 10 feet for what we consider a significant, so maybe not the highest risk, but still what we consider a significant risk is you are within 6 feet of an individual for 10 minutes cumulative, right? You walk away and come back, doesn't doesn't reset, the clock continues. You're not wearing masks, you're indoors. The important thing that we really have to reinforce here is that a test does not predict the future. After that exposure, anytime in the next 2 to 14 days, you could go on to develop symptoms. You could go on to test positive. Remember, again, not everyone who tests positive, who gets infected, who spreads the virus, ever has any symptoms. A negative test at day 2 doesn't tell you what's going to happen at day 13 or 14. A test cannot predict the future. Well, what can we do during this period here? In the US, one of the things we've been studying quite a bit are monoclonal antibodies. So instead of a vaccine and your body has to make its own antibodies, we actually give antibodies to people. And that's something that's still being studied here in the States and throughout the world. But the biggest thing I want to say here is to avoid harm and have a plan. Have a plan for what if that person turns positive? What if that person goes into the next phase? So let's talk about what we do in the next. So now we're going to move from that detectable viral replication period into the time when a person might first start to have symptoms, or they might get that first positive test. Now, in the US, there's been a lot of effort and emphasis placed on educating the public, educating physicians about what we term passive vaccination. And we have a couple of these antibody cocktails. So again, what this is with the bamlanivimab, the atezolizumab, is a couple antibodies that are really high concentration given to individuals. We're finding here in the US that if you give these within the first 7 to 10 days, with the Eli Lilly product, so the bamlanivimab, atezolizumab made by Eli Lilly, about an 87% block of people progressing at all, requiring any medical care. In about 36 to 48 hours, these people reporting, I feel completely better. The Regeneron cocktail uses casirivimab and imdevimab. We're using cocktails because of the variants. The Regeneron cocktail, about a 70% if you get it in that 7 to 10 days. What about in areas of the world where you don't have these fancy, expensive monoclonals? We've been studying serum, right? The convalescent plasma, giving the antibodies from a person who's recovered. There's still ongoing research in those areas. It looks like the time when we may have benefit there is if we give these in a smaller window within the first 3 days. There's a nice study out of Brazil on that. Maybe 7 to 10 days, it's getting a little bit late. And there's some quality and other challenges in these products. But again, it's the same idea of giving someone passive vaccination. What about antiviral therapy? Remdesivir is something that I will say, honestly, is widely used in the United States. We are not really convinced that it makes much of a difference. There was really about one study that showed much benefit. If it's doing a benefit, I have to say as a clinician, it's hard to know. It's not something where your patient miraculously gets better. Is there a subtle shortening of hospital stay? Maybe. Again, not as impressive an antiviral therapy as we all were hoping it would be. There are others, I have to say, on the horizon. We're expecting to hear some preliminary data on Merck's product in coming weeks. And actually some of the other companies have some other products. Pfizer has one in the works as well. What can you do during this time? Now, one of the problems I have to say is when we first started having cases of COVID-19, there was a communication out of France suggesting that using any of these pain relievers, any of the things to help with fevers, acetaminophen, maybe the ibuprofen, maybe the naproxen, particularly these non-steroidal anti-inflammatory drugs, maybe there was potential harm here. But fortunately, I have to say, there was a really nice study, the use of non-steroidal anti-inflammatory drugs and risk of death from COVID-19, an open safely cohort and analysis based upon 2 cohorts. So this was really robust data, over 500,000 current non-steroidal anti-inflammatory users compared to almost 1 million non-users in the general population. And there was really no evidence of difference in risk with regard to death with current use. So I think this really helps us. It can be miserable to have COVID-19, particularly during the first week, and then I will mention into the second week. It can make a huge difference to be able to offer these therapies to our patients. But now we move into the second week. And I know people are going to say, what about a few drugs that we're interested in that you didn't mention during that first week? And I'm going to get back to that in the Q&A. I'll say if I'm not mentioning it, it usually means that there is yet to be compelling evidence to guide us. I really like to say it's important. And I think COVID-19 has reinforced the importance of evidence-based medicine. So many well-intentioned interventions have actually, in retrospect, we realized ended up harming our patients. So let's move now into that second week. Now, the early inflammatory phase. What about steroids? We use certain criteria based upon, well, the recovery trial was probably the most impressive study in this area. If an individual starts to become hypoxic, if the oxygen level starts to drop below 94%. Now, a lot of parts of the world do not have access to these fancy little detectors to see where the oxygen level is. If a person's respiratory rate starts to increase, if their lips start to turn blue, things like that. There are other ways to assess the oxygen saturation in a patient without necessarily having sophisticated infrared oxygen measuring capability. If you have it, that is tremendous. That's the population where you start to see benefit to use of steroids. Do you give steroids to people in the first week? No, the evidence would suggest that actually does harm and is not helpful. So you really got to look at the clock. Where are we? You're getting it to week 2. What about that person in week 2 who seems like they're doing fine? They're still breathing in the mid-teens. Nice pink, really good oxygenation seems to be going on. Again, those people more harm than benefit with steroids. The people that you do give steroids, is it a wonder drug? Does it change everything? About a 2% mortality benefit. It's not huge. This is subtle. We're chipping away at COVID-19. What about another drug that's used a bit in the United States, something called tocilizumab, targeting that interleukin-6 pathway? Well, adding this to the right patient at the right time can give you about a 4% additional mortality benefit. But I want to point out, who is that? It is not the majority of patients. It's a minor select population. This is a patient that we are treating with steroids that is on a low amount of oxygen, but now it's progressing, a significant amount of oxygen support. And within, I'll say, 24 to 48 hours of significant escalation of support, then treating them with this medicine. And it's a fairly expensive medicine. We're talking about thousands of dollars for a single dose, but it's a very small group of patients that benefit from this. If you give this to people who do not require oxygen, if you give this without pre-medicating with steroids, again, you may be doing harm and not benefit for your patient. What about anticoagulation? This is huge, I have to say. Early on, there was a lot of concerns, a lot of communications came out of China that these individuals with COVID-19, at that point, right, it was the novel coronavirus, were at significantly increased risk of bleeding. Actually, what they are is they're at significantly increased risk of clotting. So the current evidence favors using anticoagulation in these individuals. So what's the current recommendation? The current recommendation across the board from the American Society of Hematology is to give anticoagulation for all patients, either prophylactic or full dose. And let's go into who. Most of your patients are actually gonna, we believe from some of the unpublished studies, but data we've been able to look at and review, benefit from full dose. But in a lot of your severely ill patients, yes, the risk of bleeding can increase, and sometimes it's better to use prophylactic dosing. So you really want to look at your patient and you want to gauge what are the risks here. If this was a younger, thinner, active patient, okay, maybe that's going to be just prophylactic dosing. If this is an older, heavy, sedentary person just laying there, not moving, really working hard to breathe, okay, that may favor full dose anticoagulation. What can you use? Can you just do subcutaneous heparin? Can you use Coumadin? Can you use aspirin, for instance, an antiplatelet agent? There's evidence supporting all those interventions. Definitely better than doing nothing. And what about pulmonary support? This is when people start having increasing oxygen needs. If anything, we've learned over time, keeping these people off mechanical ventilation is key. Give them the supplemental oxygen, lay them on their belly. proning is actually one of the most significant interventions we can do. Having an individual lay belly down. Sometimes the patients don't like to do this. You have to really encourage them. You have to really educate them that this is a mortality benefit. You're just not trying to make them uncomfortable. We want to use all our non-invasive ventilation methods, NIV. And again, this is the period when a lot of people receive the remdesivir. One of the arguments for why it hasn't done much is that the virus is already on the way down. The problem here is not the virus, it's the immune response. I mentioned the steroids. So what's the data? And this is a large, really fantastic, informative, ongoing study by the Recovery Collaborative Group. And this, though we got early data on this, it wasn't until the end of February that this finally got published. And this is just the data there. So dexamethasone in hospitalized patients with COVID-19, the Recovery Collaborative Group, New England Journal of Medicine, really been one of the most influential studies on changing over and encouraging people to start using steroids. But again, as mentioned, in the right patient at the right time. This shows a little bit of that difference, right? It does make a difference, but you can see it's really in the mechanically ventilated, the sickest patients that this makes the biggest difference. Remember, this is not huge. This is subtle things. So you got to keep that in mind. The steroid psychoses, the risk of infections, the risks in parts of the world where there is strongyloides or other parasitic co-infections. We're talking about 10 days in the right person. When you start giving a second or third round of steroids that we often see, then maybe we're going to get into a discussion of doing something like ivermectin if your population is a high risk of co-infection with strongyloides. What about tocilizumab? I won't spend too much time on this, but this was actually a pretty major study as far as settling some of the controversy. So the COVACTA trial, the REMCAP, another trial, and then a third trial. So this was really, I have to say, quite controversial in the United States, the use of tocilizumab. Even though we finally have good data on it, again, this is a small subset of patients that we're talking about. Most patients are not going to fall into that window. But anticoagulation, let's move on to something that the majority of our patients are going to be candidates for. So this was a study in the British Medical Journal, early initiation of prophylactic anticoagulation for prevention of coronavirus disease 2019, mortality in patients admitted to hospital United States cohort study. This was actually a 27% decreased 30-day mortality over no anticoagulation. This really moved us from discussion about no anticoagulation versus doing anticoagulation to the question of what level of anticoagulation. Are we doing full dose? Which agents are we using? Are we doing low prophylactic dose anticoagulation? What do we know about this? And I have to say, we're waiting. We just met the other day for the American Society of Hematology, frequent meeting to discuss updating our guidelines. We are still waiting for this data to be peer reviewed so that we can incorporate it into our updated guidelines. But what they've done with these 3 large studies that are really 58 sites, Canada, USA, Brazil, Mexico, 60 sites in USA and in Spain, 290 sites throughout the world. There's even Nepal there, if you look. So these are studies that are going on throughout the world. These 3 large studies have actually gotten together and unified their endpoints and their analysis, and their primary outcome was organ-free support days. And this actually favored full dose anticoagulation for the moderate COVID-19, and then that lower prophylactic dosing for people requiring ICU level care. So now we're getting a little bit of subtlety about the fact that there's different intensities of anticoagulation that benefit certain patients. And I mentioned proning, and I want to sort of reinforce this. Proning is something that we've been doing for many years. There's been data to support it makes a difference. It seems like such a simple intervention. Patients don't like it. When you're not feeling well, when you're having trouble breathing, a lot of patients don't want to be belly down. But this was actually a study, a retrospective, multi-center observational study conducted in a couple dozen, so 27 hospitals, Mexico, Ecuador, non-intubated patients with COVID-19 managed with prone, laying on your belly, versus supine, laying on your back. And you can actually see the numbers here. In these almost 1,000, so 827 non-intubated patients, less patients in the prone group required endotracheal intubation, mechanical ventilation. So 23.6 versus 40.4. Death, 20 versus 37.9. We're seeing a mortality benefit from just having people lay belly down before they end up on a mechanical ventilator. And actually, we're keeping a bunch of people off mechanical ventilation. So a very low-tech approach that can make a big difference in COVID-19. This was a retrospective analysis, really the same thing, looking at benefits in outcome, looking at a mortality benefit. Here in this study, this was a retrospective analysis looking at 105 patients. No prone patient died compared with a quarter of the patients who are not prone. So pretty impressive support there. What about this later? So we're moving through, we were exposed, we were infected, we had that crummy first week, we had that inflammatory phase, the early inflammatory phase. Now some individuals are either still in the hospital or returning to the hospital during week 3. This is when we start to see an increased incidence of bacterial infections. 99% of the patients that show up in the door here in the US are not secondarily infected when they show up. They have a viral illness that does not benefit from antibiotics. But during the secondary infection phase, we're seeing bacterial infections, treating them with antibiotics. We're seeing fungal infections. We're seeing Candida, we're seeing Aspergillus, we're seeing Cryptococcus, we're seeing all different fungal infections. Also, this is the time where if an individual was not adequately anticoagulated, adequately protected against clotting, this is when we can see a significant incidence of strokes, of deep clots. During this point, it really takes a clinician. You've got to sort out what is going on. Is this another surge of inflammation? Is it an infection? Is it a clotting disorder? And then we move into the 4th week, and this is when we see the multi-system inflammatory phase. Do we treat this with IVIG? Do we treat this with steroids? We have been, but I have to say, we're still not clear on what makes a difference. We're sort of borrowing from other diseases when we treat this. Initially, this was described in children. In the UK, we were seeing it in a lot of our hospitals for children here in the States. We're now seeing it in adults. It's well described in children as well as adults. And then we move into what really is something that I think terrifies a lot of us throughout the world, particularly me, is that people may not get better. I was treating a lot of patients in the hospital. There was this idea in the US that we would clap them out and everyone would clap and send them out the door without any follow-up because now they were all better. But we're now realizing more and more data suggesting that these people are not all better. We're seeing high readmission rates. We're seeing about 10% of these individuals are not even alive a month or 2 after discharge. We are trying to send these people on prolonged anticoagulation based upon their risk factors and based upon resources. I have to say here in the US, a couple of these medicines, the rivaroxaban, the apixaban, actually quite expensive. We're sending them out and we're finding that some of their insurance plans are not covering these. So a lot of times we're just using daily aspirin in this patient population. I think that's really troubling when we're willing to spend the resources we have spent to get them through that hospital, and now our coverage plans and our healthcare system is dropping the ball here. But we're seeing lots of long-term care challenges. We're seeing ongoing fatigue. We're seeing cognitive impairment. I have nurses and professors who trouble finishing sentences after their bout of COVID, who can't even sign their name. We're seeing a significant number of people have pulmonary compromise. Some of it looks like it's pretty significant scarring, as you can imagine, from someone who's maybe been on mechanical ventilation, who's been through all these different stages. And our cardiologists are quite busy with all the different cardiac issues that we're struggling with. So we mentioned the vaccines, and we're going to spend a little time on these, I think, in our Q&A. Probably going to focus a little bit on the AstraZeneca and the Sinopharm. And I just want to sort of leave people, or sort of finish here, think about the different phases and what we do, because timing really matters here. Early on, ideally, we want to jump in with our vaccines before people are exposed, get them vaccinated with enough time to build those protective T cells, B cells, antibodies. During that early period, the viral symptom phase, that first week after someone starts to get symptoms, or if someone starts to test positive, there's not a lot we can do that is helpful. There's a lot we can do that is harmful. Still, here in the US, I have to say, there's still a lot of hydroxychloroquine. Here in the US, where we really do not have a significant parasite burden, we're still seeing a lot of veterinary ivermectin being really highly dosed in individuals. It's that second week, that's when you start looking at steroids, not that first week. First week giving someone steroids, you can actually do harm. I think that's critical to know. And the anticoagulation is something, again, that you consider starting in that second week. So timing really matters. I think it's really important to have this scheme of different stages when you're thinking about taking care of your COVID-19 patients. And I'll just finish here. This was, as I mentioned, 35 authors from all across the US, Norway, France, Spain, Cuba, Hong Kong, Portugal, Ireland, Italy, really trying to get together and talk about the importances of the stages of COVID-19 in treatment and trials. All right, well, thank you very much. We'll have a bunch of Q&A here now. But I am very happy to answer questions. Parasiteswithoutborders.com, that's an organization I'm president of. We try to every week put an update, keep people up to speed with the most relevant literature, the most relevant advances in understanding of COVID-19. And also, I'm always happy to answer emails if I can be helpful in any way. So thank you very much. I'm going to stop the share and open this for questions.
Thank you so much, Dr. Griffin. That was amazing. I hope everyone learned a lot through this presentation. So thank you for taking your time to teach us all this. So yeah, anyone can ask a question. Just raise your hand and just ask a question.
Dr. Griffin, that was such an excellent summary of the evidence. I have a few questions. So I'm an infectious disease doctor here in Kathmandu, and we do not have tocilizumab available. We sometimes have to ask patients' families to smuggle them across the border from India. And we do that, but usually that means that the very short window of time you have to start the tocilizumab, we kind of pass it before we get it started. So I just wanted to ask you about remdesivir. Obviously, these big clinical trials have not really shown a big benefit, although the ACTT1 initially suggested that it would be useful, and it was still under NIS guidelines. What is the practice there in the United States? Have people completely stopped using it, or are some doctors using it, and in academic centers, and in some they are not using it? That's one question. And what are you doing with that, with remdesivir? Have you completely stopped, for example? That is one question. The other is regarding prophylactic versus full dose of anticoagulation. We don't really have access to a lot of these preprint articles, but maybe I have not seen, but there were some, I think there was a paper on JAMA recently which showed that the moderate dose versus prophylactic dose anticoagulation study comparing the two different doses, and it showed that the higher dose did not really give extra benefit. So just wanted to have your thoughts on that, and I will have more questions later, but I'll give others a chance.
Okay, so these were all excellent questions. So thank you. I mean, I almost feel like I planted these because they're so good. So first, I'll mention just tocilizumab, just briefly on that. I wanted to try to make the point, it's really just a small subset of patients that are even candidates for benefit from tocilizumab. So not having access to tocilizumab is certainly not the end of the world. It's very few people that benefit. And again, it's a very narrow window. If the person is decompensated and more than 48 hours has gone by, you probably are doing more harm than good with the tocilizumab. So unless it's really ready, something that could be given promptly, it's almost better to not have it as part of your algorithm. The next was, what was the next?
Remdesivir.
Remdesivir. Okay, so let's hit remdesivir. We are not particularly impressed with remdesivir. Initially, when it came out, like everyone was clamoring. We've really tried to narrow so that this is not something that every single patient gets. If a patient shows up at one of our urgent cares, one of our initial points of contact, a lot of times we will try to keep them out of the hospital, treating them just with steroids. It's 92, it's 90, it's 88%. We're not so impressed with remdesivir that we're going to hospitalize them just to get them access to the medication. When they do get hospitalized, we're just doing 5 days if we are using remdesivir. If they're starting to get better, we won't even necessarily finish the full 5 days. I often say now here in the United States, a course of remdesivir is $3,000. I have to say honestly, as if I was a patient, I would rather have $3,000 in my pocket than remdesivir in my IV. Not that impressive. So we are trying to limit the amount of remdesivir because it's just not that an impressive a drug. The next, yes, anticoagulation. At the last meeting, we discussed that specific paper, the JAMA publication, intermediate versus prophylactic dosing. And at the end of it, we really came away. There was nothing there suggesting that our current guidelines, which is that we recommend prophylactic dosing across the board, unless the patient is at significant clotting risk, is at acceptable bleeding risk. So I think we're still waiting for peer-reviewed publications before we update the ASH guidelines. I think the other thing, and if you think about this, prophylactic dose anticoagulation plus getting your patient up, getting them walking, doing other things to minimize the clotting risk, that's reasonable as well. So this is a balance. So the current ASH guidelines still say prophylactic dosed anticoagulation, and on a case-by-case basis, consider going up to full dose. But we haven't updated our guidelines yet. Just want to let everyone know that the data is out there. And as soon as that data is peer-reviewed, reliable, we can look through it in detail. I would not be surprised if we come up with a little update to our guidelines.
Yeah. Hello, everyone. Thank you so much for inviting me to this meeting. I am Dr. Diptis. I'm intensivist at Nepal Medicity Hospital, and I'm thankful to Daniel for quoting one of the works that we have been doing at 4 ICUs in Nepal. So I'm working as a principal investigator for REMAP-CAP Nepal, and we are testing these 2 domains here. So one is the anticoagulation domain, and the other one is the vitamin C domain. So I have shared the preprint of the paper that's on the peer review process, and the results will be published soon. And from that study, what we have found that earlier we started with prophylactic versus therapeutic anticoagulation, and therapeutic anticoagulation was in the dose of 1 milligram per kg of enoxaparin, and prophylactic dose was the standard of care or the usual practice. Then the prelim report from the Data Safety Monitoring Board, we had to halt the study because the effects were futile. There was no additional benefit of using therapeutic anticoagulation. So the anticoagulation in the dose of 1 milligram per kg has been stopped now. And during the analysis, it has been seen that there may be some benefit of intermediate dosing. There's a fixed dosing of 40 milligram 12 hourly. So we are in the process of amending the protocol, and we are planning to resume that domain again, the REMAP-CAP anticoagulation domain. So this study is being done at 4 ICUs in Nepal at Medicity, Grande, HAMS, and TUTH. So we have enrolled quite a significant number of patients. And I'd also like to share that we are testing the vitamin C as well. And we are in the process of adding 3 more domains to this clinical trial. and would love to share with you all in the next meeting. Thank you for this opportunity to share information with you all.
Yeah,
Thank you, Dr.
actually,
Daniel.
thank you so much for sharing this. Yeah, so I think this is right on target. This is evolving. We expect to get peer-reviewed data from all these different studies, and we'll update it. We like to say that our anticoagulation guidelines are living documents. And vitamin C, I'm very curious. So I'm friends with Paul Merrick. I think I can say we're friends. We email on a regular basis, and he is very interested in the ongoing studies, trying to sort out. Is there a role for vitamin C, for zinc, for several other of these therapeutics? And we're still waiting for the data to really guide us on where those might fit into the therapeutic.
All right. Thank you for your question. So thank you for sharing that information with us, Dr. Diptesh. I just want to say, Dr. Griffin, so like you mentioned about Dr. Paul Merrick, and I'm sure he was also part of your paper. He was also a co-author on that the phases of COVID paper, which was an amazing paper. Just wanted to ask you, because he routinely advocates the usage of ivermectin, and I think it's gaining a lot of traction lately all over the world. And I heard in Nepal, we're also starting to use some ivermectin. What do you think about that? Because based upon like what I've seen so far, I don't know what to say about that right now, because the evidence is, I don't think the evidence is actually quite there. And also one of the major limitations that I've seen is there's no consensus on like the perfect dosing, what's the dosing strategy? Because some trials are doing like 5 days, up to 200 microgram per kilogram, I guess. Like twice a day for 5 days, or some studies are doing like once every 3 days or something like that. So there's not a common consensus on the dosing strategy. What do you think about that? And and if you have positive thoughts about this medication, in what phase would it be most beneficial, like as a prophylactic therapy? Because Dr. Paul Merrick and Dr. Pierre Corey, they've been recommending ivermectin for pretty much as a prophylaxis or as a treatment measure in the early inflammatory phase, and even on the tail phase, for the long COVID syndrome. So what do you think about ivermectin in general?
Yeah, I'll step in this, which is what I always feel like it is when I bring up ivermectin and talk about it. And I'll quote an email from Paul Merrick to me, which was, quote unquote, "Dan, some stuff you just know is true. You can't study it." You can imagine I am not of that school. I am of the school that, evidence-based, you can test things, you can find out if something works. A lot of the passion around ivermectin is ivermectin does whatever you want it to do at whatever time. Early on, it's going to boost your immune system. Then when you start having an inflammatory storm, it's going to modulate it right to where you need it to be. Oh, and by the way, it's also antiviral. And then when you're in the long phase, it's going to fix you all up too. So somehow ivermectin has taken on this magical ability to cure all ills. I actually think that if you take ivermectin, you might win the lottery, would be the next thing that comes out of this. This is not evidence-based. Is it worth studying? I think it's worth studying. I think there's a lot of people that are interested. But how did this whole ivermectin story start? There was a group down in Australia, and they published a paper with, I really think was an inappropriate title, and it was FDA-approved drug ivermectin is able to inhibit SARS-CoV-2. And what they did is they put so much ivermectin on top of cells to get to this serum level, a person would have to take 10,000 ivermectin pills. I'm not sure if that's even physically possible. Now, that was not a great study. But it did get a lot of people excited, and it got this ball rolling. There have been a few studies here and there, but none of them have really been, to be honest, high quality, compelling. So their argument has jumped from, well, if you're waiting for the randomized controlled trials, if you're basing your edge, maybe we should just, be evidence-based without evidence, I think is where it's going. So I'm going to put a damper, I think, on ivermectin. In the areas where I have seen the suggestion of benefit, they actually correlate with areas with high incidence of strongyloides. And when I work with colleagues, the amount of steroids that are being used, when someone gets 10 days, 20 days, 30 days of steroids, and you're living in a part of the world where 30% of the population has a strongyloides co-infection, they probably need a dose of ivermectin, not to treat the virus, but to treat the parasites. So I think, in my mind, that's where ivermectin fits in. Ivermectin, I think, is a good anti-parasitic. It's proven in that. Not really convinced yet that there's any really compelling data on it as an antiviral. I'm really not convinced that it has immunomodulatory capacity. Do I think it's worth sorting it out? Yes. And I think that's where our NIH stands right now. Say, we don't know what to do with ivermectin. We don't have any compelling evidence to know whether or not it really is going to make a difference. And I know there's a lot of passion, but again, there was a lot of passion around hydroxychloroquine, and we saw this very quickly happen in the US from people, family members calling up, if you don't give my loved one hydroxychloroquine, I'm going to drive my truck through the wall of your hospital and give it to them myself. To a week later, if you dare give hydroxychloroquine to my loved ones, I will drive a truck through the hospital. And so, I think it's unfortunate that we're a year in and we don't really have clarification on a lot of these therapeutics, such as ivermectin. We also certainly have no clarification on doses. And the problem we're running into in the US is people are going to their veterinary stores. They're getting horse ivermectin cream. They're getting horse ivermectin pills. They're taking the ivermectin that is supposed to be for their dog or cat. So it's a little bit of a wild west here. That is actually one of the most compelling reasons why I think we need to have this studied, so we understand if it does make a difference, when and at what dose.
Exactly, because lately I've also seen a lot of uptick on the prescriptions being prescribed for ivermectin, and the dosings they don't really make sense, because a lot of the doctors that I've seen, they are for example, one doctor just sent me a prescription for ivermectin, about 12 milligram, twice a day for 15 days. I'm like, I've never seen that dosing for 15 days. It just did not make any sense to me.
Yeah, I actually
these kind
say
of things are happening.
The people on this call are probably familiar. They probably used ivermectin, right, to treat scabies, to treat, parasitic diseases. A lot of the people grabbing ivermectin are not familiar with the medication. They're not familiar with the dosing. They're not familiar. And here they are using it in COVID-19. So I'm very much evidence-based. I think unless we really understand a medication and we have proven benefit, as I think we've seen, we can do harm to people.
I wanted to just mention what we normally do regarding ivermectin is, as Dr. Griffin said, we don't use it routinely. And in Nepal, we cannot even test serology for ivermectin, for strongyloides. So we actually have to use it empirically. So basically, we just use it on people who have been on steroids for severe COVID, and now are getting worse. And especially if they go into shock, we use it empirically. But other than that, it's hard to justify or hard to know when to use it. My question is regarding steroids. So in practice, we see a lot of patients who need more than the recovery trial dose of steroids. There have been cases where in the past we used to just use the 6 milligram per kilogram, 6 milligram daily dose of dexamethasone, and the patients would get worse and they would be going into ICU, and we just would keep using the same dose, and over time they might improve, but we didn't know what to do. But during these past few months, we have learned to increase the dose of steroids if they start to get worse, if their oxygen requirement increases, and after if the CAT scan just shows ground glass opacities rather than a bacterial or fungal infection looking appearance. So but there is very little evidence from big trials to go by. Are you aware of any studies on higher dose steroids for certain subsets of patients, or what is the best approach to increase the dose of steroids or use the alternative dosing of steroid for different patient phenotypes?
Yes.
Thank you.
So actually, what you're describing is actually very similar to what we're doing in the States, particularly in our ICU patients. If their oxygen requirement is going up, we will increase. The idea is they studied the 6 milligrams once a day for 10 days, but it's not one size fits all. For someone who's more severe, someone who's headed towards the ICU, maybe someone who's even in the ICU, will very quickly go from 6 up to 10 milligrams a day. We may not just stop at 10 milligrams. I have an individual right now who has been on, he was on 6 milligrams for 5 days, 10 milligrams now for another 5 days. We're going to go a couple more days before we even consider tapering down. You're right. There are no really large recovery size trials, and I don't think there will be. I think the question was answered. Steroids make a difference. There are smaller studies suggesting that different doses of steroids might be a benefit for different patient subsets, particularly higher doses for your more severe, your patient who's progressing despite the 6 milligrams. Also think about size, right? A 300-pound or your 120 kilogram individual versus, we'll say, a 50 kilogram or 110-pound person. It makes sense to start thinking about other factors and trying to personalize the dose of the steroid. So yeah, we don't feel like there's a necessary rigidity to the 6 milligrams in only 10 days. And again, that's exactly what you bring up, is where we think there is sometimes a role of ivermectin. Let's say you continue. Let's say they've been on the steroids for 20 days. It's really past 14 days when we really start to see the strongyloides issue. We've actually seen, even here in the States, where we have a lower incidence, where a person on prolonged steroids will start getting worse. And actually in the sputum, we'll actually have strongyloides, and we'll see them, with the serpiginous tracts all across the agar plate.
May I also ask regarding the dosing in post, discharge for steroids? Do you suddenly stop at 10 days, or do you actually taper it over time? Most of the patients, what we have been doing is initially we were just using the 10-day dosing, and then we realized a lot of them relapse. And then we have to use steroids again. And there has been a certain population of patients for whom, as soon as we taper the dose down to a certain level, they flare back up again, and we have to increase the dose and they get better again. So there has been this subset. So we have been tapering over usually 15-20 days. Rather than stopping abruptly at 10 days. We actually start to decrease the dose way before 10 days, usually at 5-6 days when they are ready for discharge. We start tapering down the dexamethasone dose, but we don't really stop at 10 days. I wonder what your practice is.
Yeah, we're routinely, so our sort of general practice is 6 milligrams a day, 10 days, but then we are individualizing, right? Let's say the person, is larger, they had more severe respiratory issues. Maybe they have underlying, chronic obstructive pulmonary disease, which, I remember was quite a prevalent issue there in Nepal. These are individuals that we will consider tapers. So yeah, there's clinical judgment here. There's an algorithm, there's the here we start. But I think as you're describing, if you try to just drop that on everyone as a rigid rule, rather than just sort of guidance to get started with, you're going to have exactly what you described. So yeah, I think over time, when the recovery first came out, it became check that box, 6 milligrams, 10 days. We have a lot of computerized records, so that became a, click a box and that happens. But a lot of times there is exactly what you're describing. If you stop it abruptly in an individual who's maybe still requiring oxygen, other situations, they may be right back and back on the steroids. So yeah, tapers are something that I think you need to think about in a number of your patients.
Mark, so quick comment from you, Dr. Griffin, about the long COVID syndromes. And we've been reading the news, like a couple of vaccination has been helping these individuals. So what's your thought on these people? And a little bit of your, what do you think about this long long setters as well, like people with immunocompromised conditions shedding the virus for a long time. So we are reading a couple of here and there saying like the B117 mutation has been evolved from this group of people. So what do you think about them, how to manage them?
Yeah. So yeah, this is, I'm glad you bring this up because I was sort of thinking we needed to go here. So what about vaccines? What about vaccines and long COVID? What about natural infection? Oh, I was infected. Now am I safe? So we just admitted an individual over last night. And this is an individual who initially had COVID back in the end of March, right? So early when we were really getting hit here in New York pretty hard. This individual went ahead and, here we are in the US, he got access to his first vaccine about 3 weeks ago. So he was very excited, because there's a lot of controversy, right? Oh, you've already had natural infection. What are you doing? Do you even need to get a vaccine? The other, if you get one vaccine, do you even need that second dose of the Pfizer? And he, as I mentioned, he got admitted to the hospital last night with acute COVID again. He's on oxygen, he's on remdesivir, and his SARS-CoV-2 PCR is positive. So what we think we're seeing is that you may get a natural infection. It may protect you against the original, so the Wuhan B1 strain. But what about these variants? They are changing the areas where our antibodies like to target. We don't think natural infection protects you against these new variants. We also think that the waning level of antibodies may actually be part of the selective pressure driving. And if we look, where are we seeing B117? Where are we seeing the different variants? In places where there's a big chunk of people who got infected the first round, it makes sense. So yeah, we're really encouraging as much as possible for everyone to get vaccinated. I know right now we look at it, maybe 700-800 million people have gotten a dose of vaccine so far. We live in a world with 8 billion. That means very few people have been vaccinated so far. Even we hear numbers about, oh, we're gonna have 2 billion vaccines this year. Again, that's a quarter of the world. That's not there. Until we really start getting these vaccines out, this is a problem. Not only can people get reinfected, and I like to point out, sometimes that reinfection is worse than the initial infection. I've certainly, unfortunately, had people who the first time it was mild outpatient, second time they end up in the hospital, second time they actually have died, right? So that's worse. So just thinking that you got it once and it wasn't so bad, I'll be fine. The second time can be worse. That natural infection does not protect you. Just person in note, right? Sort of on my service right now. We need to get these vaccines out there. The other is that we are seeing, not in patients who have significant pulmonary scarring, who have permanent heart damage, but a lot of these other individuals with long COVID, with the cognitive challenges, with the fatigue, we're seeing a chunk of them actually recover with vaccination. So vaccination currently is, I think, our most potent, powerful therapeutic for long COVID. I guess I will mention while we're here about the different vaccines, right? So they're in Nepal, right? The Chinese have been super, I think, generous with Sinopharm, right? So there's Sinopharm vaccines rolling out. The AstraZeneca, if you're following the news, there's some questions about the AstraZeneca, right? There's a potential related blood clot disorder. It's being described about 1 in every 600,000 person who's been vaccinated. It's actually below background population, but what they're saying is, but within the 7 to 14 day window, that might make it significant. So again, if there is a connection here, there might be. It remains very rare. I mean, a 1 in 600,000 chance is low. What a lot of countries are doing is they realize that they're only seeing this phenomenon in younger individuals. So some countries have said AstraZeneca will be for people over the age of 30. AstraZeneca will be for people over the age of 60. They're sort of trying to say we'll use different vaccines in different age groups. I don't have any particular concerns with Sinopharm. I think the data on Sinopharm was pretty impressive. So it's tremendous that will be an option as well. And it may be a question of, balancing your risks. Boy, if you're 60 years old and you're living in a pandemic and you have access to AstraZeneca, yeah, that would be a great choice. It's much safer. Your, 1 in a 600,000 risk is much lower than the risk of getting COVID being unvaccinated. So again, there's a balance there of risks and benefits.
All right. So what do you think about, what are your thoughts about mixing two different kinds of vaccines, because in a country like Nepal, like we rely a lot on international aid, and recently we got a batch of the Covishield vaccine, or the AZD 1222 AstraZeneca. Uh, but I mean, maybe the next time we get something, maybe we'll get something else completely different, like Sinopharm, or maybe even the Russian vaccine Sputnik 5, or maybe, I mean, maybe J&J, who knows, What do you
Okay.
think? Because I know there's no evidence to guide this right now, but what do you think about, because it's very important for a country like Nepal. I mean, in USA or in Western countries, there may not be any issues with like, the availability of the vaccines, of the same vaccine for the repeat dose. But in Nepal, like, it depends upon what we get at that time, right?
Yeah.
So I don't think we have a lot of the AstraZeneca vaccine right now. So we might be using Sinopharm at some point. So that means a lot of the people who got the first dose of AstraZeneca, they may not have time for, they may not have the dose for the second dose.
Yeah.
We may not have enough for the second dose. What do you think about combining that with Sinopharm inactivated vaccine? Is that a viable thing that we can do?
Yeah, so I think there's two ways to answer. So one is the very strict evidence-based, have we specifically tested, one vaccine, second dose of a different platform? That's actively being studied. But what do we know? I mean, we do have a whole background in immunology. We've been vaccinating people for really a long time. And if you look at the different, the different timing, the different way we vaccinate, 3 weeks, 4 weeks, think about how we do hepatitis B, think about how we do shingles vaccines, 2 months, 4 months, even 6 months after the first. So we understand a lot about how the immune system responds. Almost all the platforms are pretty much providing the immune system with the ability to see spike protein. The Sinopharm, the inactivated, you get to see even a little bit more. You're also seeing nuclear capsids, some other proteins. I think of all the science up to this date would suggest that mixing and matching is going to be just fine. Here in the US, I joke about, Coca-Cola, I know that's quite popular in Nepal. Moderna and Pfizer, one of them is getting your Coca-Cola in a bottle and the other is getting your Coca-Cola in a can. I'm not sure why one is 3 weeks apart and one is 4. There's no real science to suggest that there should be any difference there. And if you look at the AstraZeneca vaccine, you look at the J&J, you look at the Sputnik V. I think it's a V for victory, actually vaccine, not 5, not a space race. We lost that one, I think. But there's no reason to think you can't mix and match a lot of these and really get good efficacy. So I think that's going to happen in lots of the parts of the world where you're going to get one, you're going to get the second one. It's going to be a different platform. I still expect people are going to get a robust boost. And we'll have really specific science on those issues in the future, but all the science, all the immunology we know to date would really suggest that that's going to be just fine and effective.
Thank you so much, Dr. Griffin. So yeah, I think there are some ongoing studies with combining Pfizer with AstraZeneca and Gamaleya, or Sputnik V with AstraZeneca vaccine. So hopefully we'll see the results from those studies soon. So looking forward to that. Then maybe that can guide our decision in the future. Anyways, thank you so much for everything, Dr. Griffin. Thank you so much for taking your time despite your hectic schedule to be here with us and sharing your knowledge to all of us. It's been a great experience, and hopefully we can do this again at some point again.
All right. No, it's been great. Thank you so much. And thank you everyone for taking out the time, and be safe. Be safe. This is not over by any means. So